Good evening and welcome to the special NDTV Dialogues, where we focus on ideas and the big idea in India, celebrating the 1 year of the Prime Minister's flagship health insurance scheme, Ayushman Bharat, which actually celebrates or looks at covering expenses of 5 lakhs for over 10 crore families, and that scheme is growing every day. Now it's 1 year. Joining me tonight is a very special panel. I'm joined by Dr. Indu Bhushan, who is the CEO of the Ayushman Bharat program. Also with me, a panel of India's best doctors and, of course, also hospital administrators. I'm joined by Dr. Randeep Guleria, Director of the All India Institute of Medical Sciences. Also with me is Dr. Ashok Seth, Chairperson of Fortis Escorts. I'm joined by Dr. Sangeeta Reddy. She's Joint Managing Director of one of India's biggest integrated healthcare providers, Apollo Hospitals. Also Dr. Devi Shetty of Narayan Hrudayalaya. Again, it's often called the Walmart of Indian health, famous really for looking at how he can provide best quality healthcare at low prices. Thank you all very much for coming here, Dr. Indu Bhushan. I remember you came into this studio and program 1 year ago. 1 year later, what's the big learnings you've had in the last 1 year, the biggest rewards and the challenges ahead?
Well, a lot of challenges, but let me start with rewards. So we have now given more than 45 lakh treatments. And in first year, if you had asked me in the beginning of the year, I wouldn't have thought 45 lakhs would be possible. We have more than 18,000 hospitals coming on board, and we have committed more than 7,000 crores. And actually, if you look at the patients, they have actually saved more than 14,000 crores. So in that sense, we are very pleased with the initial momentum, but we have a long distance to go still. We have to work on the last mile. We have to ensure that awareness, especially in many underserved areas, grows. Also, we need to get more tertiary care hospitals involved, and also we need to ensure that quality of services remains acceptable in all these in the treatments that we provide, and ensure that there is no fraud and abuse.
So, when as I said, I've got India's best doctors here, I'm going to let each of them actually ask you a question because they're the experts in this. So I'm going to start with Dr. Randeep Guleria, who of course heads India's biggest medical institute, the All India Institute. Dr. Guleria, what would you like to ask Indu Bhushan today?
So I would first like to congratulate him on this scheme, which is a game changer as far as the health sector is concerned. The challenges, I think, is how to implement it so that it reaches everyone, even the poorest of the poor and people in remote areas. Also, like you said, making sure that it's done in a proper manner, it's not exploited, there's no overcharging, and there's no corruption. So how do you think these challenges, how would you face these challenges in the future? Because
there have been instances reported of some private hospitals, I think, who had inflated or made false bills for, I think, cesareans it was.
Well, you know, we have a zero tolerance policy against corruption, against fraud or abuse. And we believe that our system has large amount of checks and balances to prevent that. All those packages which are prone to fraud and abuse are reserved for the public sector. In addition, for all those where fraud is possible, we have a very strong system of pre-authorization. Hospitals have to show documentation and prove that those procedures are required. We also have a very strong data analytics to identify cases which could be suspicious, and based on that we conduct medical audits. And what we see in the press or newspapers is actually those cases that we have caught proactively. And we have suspended more than 300 hospitals. About 100 hospitals have been de-empaneled. We have filed FIR against 6 hospitals. Therefore, these actions have been taken because we have been proactive in catching them, and we will continue to...
It's not just doling out money.
Yes, and we will continue to keep our systems alert and ensure that the fraud and abuse don't take place. And if they take place, we take exemplary action so that others don't follow.
I want to bring in the representatives of our private hospitals. So, Dr. Sangeeta Reddy, if you could just come in, because of course Apollo, one of the biggest healthcare providers across India, what have you seen as what would you like to ask Dr. Indu Bhushan of this 1 year of Ayushman Bharat? And I remember that there were points raised last year also about the whole costing issue and the kind of debate over the profit factor in an area like health?
So I think I would add my congratulations to Dr. Bhushan as well as to the Honorable Prime Minister for the power of the vision. I think that this is something that we have said before, that the idea of universal health coverage is amazing, it's important, and it's a concept that we've been working on for the last 20 years. And when that vision is coupled with the concept of the health and wellness centers with preventive care, I think this is one of the most significant steps to making health a national priority and bringing health within the reach of everyone. As Dr. Bhushan knows, and we respect him very much with a background like he has, I actually have two questions. One, because in a number of states where we operate, we are currently working with the state schemes. So whether it is in Tamil Nadu with the Chief Minister's scheme, whether it's in Telangana or in Andhra Pradesh with the Arogyasri, in Bhubaneswar, in other states like in Jaipur, etc., where with Bhamasha, and I know that Bhamasha is moving into the Ayushman Bharat. So my first question really is, how do you see the movement of the states into this unified scheme? Because we believe that a large national unified scheme will bring you the scale, will facilitate the type of investments you need in the technology, will enable you to do the data crunching and become far more proactive about care. So my first question really is, how do you see the states moving? So with a deep sense of respect for, all the knowledge that he has and, which the whole scheme, and a lot of respect for the way the team has managed to bring in these volumes it's just 366 days. And I think it's quite amazing what has happened. The pressure on the private sector. So my question is not, when are you revising the tariffs? I think my question really is, how can you find a way to appreciate that high-end hospitals like Apollo and others on the panel will get some of the sickest patients, and therefore a standard package doesn't appropriately reimburse for the complexity of that patient? So when can we start doing some differential pricing for high acuity patients? So these are my two questions, and thanks for this opportunity, because I truly believe that we're partners in delivering this care, and Apollo is very committed to this partnership.
Well, excellent questions, Sangeeta. So on the first one, which was easier one, I must say that states have been now more and more converging towards PMJ. And as you mentioned, Bhamasha actually has merged with PMJ as only one scheme now. And one side benefit of this scheme has been that because of the scale, a lot of small schemes have started to merge or converge towards this scheme. And because this has provided them a framework or fulcrum on which other schemes have come around. For example, in Karnataka, they used to have 7 schemes, and now they've merged all of them and come around PMJ. Similarly, Kerala had 3 schemes. Now it's only 1 scheme there.
So it's nice that the political divide didn't matter then.
And Chhattisgarh also has 7 schemes, and they are now merging together into 1 scheme. And that, like Dr. Reddy was saying, has a lot of benefits because it cuts across some red tape. And for hospitals, now it's a 1 scheme, so they don't have to see, okay, person X is coming for scheme Y has these packages, these rates, and this kind of form to be submitted, and scheme X has something else. So it makes the life of hospitals easier. Also at the level of beneficiaries, someone is coming, their benefit package is some different, and they're covered up to only 1.5 lakhs. Someone else is coming, they're covered up to 2.5 lakhs. And so there is a lot of confusion. Now with the convergence, it's a 1 scheme. Maybe the funding is coming from different directions,
so it's
much easier. Reporting is much easier, and for people also it's much easier. So the movement is towards that direction, and PMJ has made it happen.
I'm going to come back, ma'am, on that question on pricing, because I just wanted to actually on that aspect bring in Dr. Devi Shetty on that, because of course Dr. Devi Shetty, I remember when you first began really talking about the fact that there's going to be no person who will be turned away from your hospitals because they can't afford it. And you've actually worked out a private sector low-cost model, even with the complex heart surgeries you're doing. In fact, in some cases, and I had those figures, the cost of the operation in your hospital is actually cheaper than the package that even Ayushman Bharat is saying. So how do you manage that profit model? And then I'll come back to Dr. Indu Bhushan with your question and Dr. Reddy's and Dr. Seth's question. Go ahead.
See, about 15% of the heart surgery done in India is done by us. So naturally, by the economy of scale, we are able to reduce our cost. But as I said, there is a limit to which we can reduce, but a lot of things have changed. Now the minimum wages have increased, the salaries of everyone has increased, electricity charges have increased. So we are finding the pressure, we are under tremendous pressure now, and I'm hoping that Ayushman Bharat will be able to relook at the pricing strategy, especially for complex procedures. But I have a suggestion to Dr. Indu Bhushan. My suggestion is, with the power you have now, with the volume of patients you cover, this is the best time to digitize healthcare in India. You are in a position to give the guidelines as how the medical records should be maintained, how the electronic medical records should be maintained. And as long as these electronic medical records are not very expensive, this is a great opportunity for us to go for digital healthcare, which will make healthcare safer, it will make accessible and affordable.
I fully agree with the last part of your question or suggestion, Dr. Shetty. We are actually moving in that direction, and we will become the core of this electronic digital health blueprint, because we are dealing with the 40% of the population and a large number of treatments, so we can start, and probably the national digital health can grow around PMJ. Coming to the price, Sonia, this has been a sticking point right from the day one when we started to design the scheme, and we've been saying consistently what I think Dr. Shetty alluded to, that we are going to give large volume, and so there has to be some consideration for those volumes. And I understand that economies of scale work to some extent. After that, of course, we have to make these rates viable and attractive for private sector, otherwise they won't come. And so here we will work with the industry to ensure that we can bring in, through collective bargaining, some price reductions in the supplies or the devices and implants that they use. And at the same time, by providing them volume, probably hopefully they can also look at the efficiencies that they can bring in at the hospital level. And what we've seen is that we've given 45 lakh treatments so far, more than 45 lakhs, and out of those about 30 lakh treatment have been given by the private sector. So therefore, it's difficult to say that these rates are not viable or totally unviable, because otherwise 30 lakh treatments wouldn't have been given. At the same time, we realize that for some treatments, the rates were not in line with the cost. Right. And so we've taken a huge amount of exercise together with actually public sector and private sector colleagues, and we had gone to our governing board last week, and we are coming out with the new packages. Actually, we found that some of the package rates were quite high, and we are actually reducing the package rates for about 50 or 60 packages, but we are also increasing the package rates for many of them, especially
the complex ones.
For complex one, tertiary care, oncology, and those are being increased.
Dr. Ashok Seth, would you like to come in there? Because of course, one of the ironies or facts of Indian health is that 80% is provided by the private sector, and many who would look, and we'll look at that, who are looking at India's healthcare system would say that is a problem. Why is it the fact that the government has not actually increased infrastructure to make that burden actually more equitable? Go ahead.
Sure. So firstly, of course, I'll echo what has been said in terms of congratulations. Congratulations to the Honorable Prime Minister. Congratulations to you for this most disruptive frugal innovation which ever happened in the healthcare space, and is a transformational scene. I think it's going to change the scene of healthcare delivery forever. And it's not just a thought process. It's in action, it's there, it's a reality, and with conviction and progress under your leadership, it's shown its results in a tremendous manner in a year's time. It's holistic, it's down from primary level to tertiary level. And the one thing I like, and I must express this to you, Dr. Bhushan, is your transparency about the facts. Always you've expressed what you haven't thought through, how you've instituted in some of the points you'd missed, and been open to correcting it. And within a year, you have a 2.0. So you've actually sat around, ironed out the facts so that it does help people. Having said that, and we always understand that you are extremely have worked tremendously in your team towards the success of this, is this 2-3 aspects around it. You yourself said that the success of the scheme actually is, yes, the patients benefiting from it, but your partnership to the private institutions. And the success of the scheme is going to be gauged by that in the long term as to how this partnership progresses. And is there a trust, transparency sitting on the same side of the table? But what we've seen is, despite the fact that you may claim that 8,000 private institutions have joined it, we're actually still devoid of those tertiary centers, we're still devoid of the multi-speciality issues. We're still talking about how do we get them in the fold, and truly the scheme doesn't succeed till it's all in the fold. My question to you is, there are 2 aspects to it. One, you may say that it's economies of scale, but as you bring the cost down, it becomes non-viable, even though multiple tertiary level, even quaternary level institutions would like to support the scheme. After all, this is our future. And yet they, having mulled out the numbers, having actually worked out within the system, can't actually know that they can't be viable for the institution, because the institutions have been created at a different time frame and not to meet up the cost of this scheme. I'm now wearing not an organizational hat, I'm wearing a leading clinician's hat for 30 years, where I'd actually tell you, how do you actually ensure, firstly, quality could suffer beyond a particular point of payments, quality for suffer, and we still haven't devised a robust manner to judge quality. Low-cost care cannot translate into somebody having a third-rate treatment. It has to be similar to the ones we give at a tertiary center. So that's my first question to you. And my second question is that it's good that you have revised prices, but I think the concern is, how did this pricing come about? Is there a panel? Did it involve certain private players into it? Is it ad hoc policies around practice? Is it somewhere wishful thinking? Or is it a panel totally dissociated from the private system and the private sector who decides about the revised pricing?
Go ahead, Dr.
Both excellent questions. On the first one, you're right. Our target is to get most of the top 200 hospitals on board, and they have 2 concerns. One, that they have bad experience with some of the ongoing schemes where the payments have been delayed or not been made, and in some cases they are waiting and watching and seeing whether we are also the same. And through our track record so far, we've been trying to make them comfortable that you join us, we can ensure that payment is done on time.
Which it
and
has.
If
it has
within the states, within 15 days, and if the people are from outside the state, within 30 days. And I was told that so for some aims, Dr. Guleria is here, the payments have been delayed, and we've done an extensive analysis to show that we'll be sharing with you that 85% of payments were done within 30 days, and actually 32 days is our average time, which is slightly more than 30 days, and we will try to fix it.
Right.
Second was that some of the rates were totally unviable, and as I mentioned that we did find that some of the rates were totally unviable, and what we've done is that we've looked at those rates, and which leads to your second question, in a scientific manner. There was a study done by PGI Chandigarh where they've looked at different components of costs, and we found that it's not that easy to get a one national rate, given that cost structures vary according to the level of hospital, where they're located, and many other factors. But we've done the best that we can do. But we also done one thing, that earlier these rates were lump sum rates for the entire package. Now we have divided them into devices or whatever implants which are being used, plus procedures. So there are, we have these two rates. So that it has two benefits. One is, earlier when you have a composite rate, then there is a tendency to cut corner and give the lowest quality of implants. Now, since we have two differential rates for procedure separately and for implant, we have quality.
So, in fact, I'd just like to also, in those points, actually just expand the discussion. Look at the larger issue of healthcare. And Ayushman Bharat is, of course, one aspect of it. But I'd like to bring in Dr. Guleria and everybody in the panel on this. Is the fact that we're not able to provide quality healthcare through the government institutions mean that, of course, where the private sector focus will be quality healthcare, but with the underlying bottom line of profit? So, is the problem perhaps, and we've discussed so much on pricing, but is it more that if a similar amount of money or investment is done in providing government hospitals which are of a similar quality, and we've seen that happen with institutes like AIIMS, which are still not as widespread as they should be, why shouldn't it be that, should the underlying motive be profit? Should the issue be more about the fact that you can provide quality healthcare in an institute like AIIMS? Why should being the cost be the issue, or the issue for quality?
So, I agree with that totally. We need to look at the broader picture. Currently, Ayushman Bharat is looking at getting a lot of private hospitals on board, which are looking at a profit model, which is different from what the government hospitals are looking at. And health itself is a social responsibility. So, we should be able to provide health across the board at high end with good quality. For that, we need to really strengthen the government system, which means infrastructure, which means more resources, which means more manpower. Doctors going to these hospitals, they are having the resources that are needed. Unfortunately, the problem that happens is that health is also a state subject. So, there are certain states which do very well as far as health is concerned, because the investment is much more in health. Some states in the south. There are some states where health is not given that much of priority by the state, and that creates a problem, because then there is a lack of infrastructure, the primary health doesn't work, and a lot of people from there then go to Delhi or AIIMS or other tertiary care hospitals, which leads to overcrowding. So, the model that we need to look at, which is also being looked at as part of the wellness centers, is how can we improve the government sector at a secondary or a primary level, so that there is a good sort of balance in terms of infrastructure, in terms of resources, and in terms of manpower. Unless we are able to do that, we are only looking at one end of the picture, which is basically the tertiary or secondary care. But tertiary and secondary care is only one end. We need to look at a lot of preventive health and look at building up the whole infrastructure at different levels.
And of government hospitals, government doctors. In fact, I want to ask Dr. Shetty, Dr. Reddy, both of you, and Dr. Seth, is profit a dirty word in healthcare? I mean, that's also one of the larger aspects, because of course in Delhi there was the argument that subsidized land was given to private hospitals. So why are the rates, I mean the allegations that, you know, medical tourism, 5-star hospitals becoming like 5-star hotels. So what is the private model? Is the private model for healthcare in India broken? Dr. Shetty, go ahead.
If a solution is not affordable, it is not a solution. So we are really trying to reduce our cost and make it affordable. Now, if the hospital doesn't make profit, obviously you can't upgrade the infrastructure, you can't hire the talented people. So there has to be a fine balance. We have to, and most of us have learned to differentiate between need and greed. So as long as we know what is the need for growth and the future expansion and good quality, there is no harm in keeping a margin, but it can't be an insanely high margin in terms of patients getting fleeced.
Dr. Sangeeta Reddy, to differentiate between need and greed, because of course one argument will also be that this whole kind of commission system which started in the private healthcare system, the malpractices which sometimes occur, why are that not being focused on, and are the issues of profit levels or the issue of 5-star hospitals as are described, are those valid issues that perhaps the private healthcare sector needs to be looking at? Also the issue of whether the government hospitals need to be now upgraded rather than private hospitals then being the ones who in a sense are benefiting from Ayushman Bharat.
So Sonia, today is actually our 36th anniversary. September 18th, 1983 was when Apollo Hospital Chennai was started. And I think if you ask the 200 million patients whose lives we've touched, there is no question whether private should exist. And it is very clear from the numbers, the number of hospitals that have come up, the fact that even in a scheme like Ayushman Bharat, 62% of the care was given in the private sector. So my request to everyone actually is, let us stop this debate about public and private, because all of us need to work together. We need to put the patient in the middle and create a patient-centric continuum of care. We must focus on prevention. We must focus on social determinants of health. Even today, there are people with dengue and malaria. So we must focus on malnutrition, and I commend the government scheme on that. So first, social determinants of health, preventive health care, cost-effective care with standard treatment guidelines, which is accessible to all, but which has quality. And then again, I would put to everybody, it is the private sector that has driven innovation, has telescoped the developments of the Western world and brought it here to India, obviating the need for Indians to go abroad for treatment, and not only that, attracted international patients to come here. So let us start being proud of our private sector, let's support them, and let's work in partnership, which I think is really the dialogue that we have been having with Ayushman Bharat, with Dr. Indu Bhushan, and with government. We're not something different. We are Indians, our heart beats for India and Indians. There may be a few bad apples in the system. Those should be corrected. There should be systemic, definitive action against negative practices happening in healthcare. I'm glad that there is a fraud detection system. These things should be weeded out. But for that, the private sector, which has contributed so much, should never ever be looked at with a negative light. We are partners. And actually the patient understands. They know how to go seamlessly from public to private. They will procure medicines for TB from the government system, but come to a private doctor for care, and they'll go to a diagnostic in a private system because they trust those reports. So let's really say that we don't worry about who's public and private. We control quality.
Dr. Indu Bhushan, you want to comment on that? Because you, of course, have had experience in other countries, in South Asian countries, where the healthcare system is a very different model from the Indian healthcare system. What do you think about this whole private sector dominance, really, in Indian healthcare?
Sonia, even after 70 years, where we have invested so heavily in public sector, 70% of treatment is provided by the private sector. So private sector should not be a dirty word. And
but that's not an encouraging statistic. In fact, it should be the opposite. Why is it that government healthcare is left behind?
Well, maybe private sector has invested much more than, and maybe the quality is much better, or those are debatable things. Of course, public sector has a role to play. Of course. And because they have to provide the benchmark, they have to provide maybe R&Ds, and they have to provide education, no doubt about that. But public sector funding, providing services through public sector may not be the most efficient way to go about it. So if private sector can do it better, probably we should rely on private sector, and provision and financing should be seen separately, that maybe private sector can provide services and they could be financed by the public sector, which is what Ayushman Bharat is doing. I can give you one very example, a good example, which happened actually in one of the Delhi hospitals, and I'll not Delhi government hospital. The patient went there and he was told that it will cost about close to 2 lakhs, and you have the money. And he said, of course, I don't have the money and I'll arrange for it. And so he arranged for the money. And then he found out that through some case that he is eligible for Ayushman Bharat, and he had done all the work in that hospital. As soon as he found out that he was eligible for Ayushman Bharat, he said, then why should I get the treatment done here? He went to Noida and got it done in a private hospital.
Well, so no, I guess that's one way of looking at it. Dr. Seth, go ahead. It's not nice that there's a lack of faith in the public sector health system also. I mean, in most developed countries, government healthcare, government education is seen as a social responsibility.
Absolutely.
The state has to its
and
citizens.
usually is better than the private sector, I would say.
Yes.
But the private sector has invested heavily into it, and it was a good partnership after all. It's been the government's initiative to promote private sector throughout, and that's why it's grown to such an extent and served the nation, just as so Dr. Sangeeta Reddy pointed out. That's what brings me to the important point. Why is everyone sitting around the table who are actually complementing this scheme also saying that we're not a part of it because it's not viable? And none of the people you see around the table want to profit from it, but it's all talking about even viability. Dr. Bhushan, you had a great opportunity in your 2.0 scheme to actually say, what is the real cost of treatment? And you know, there is a FICCI data which is already out saying, sometimes the cost of these procedures, even at All India Institute of Medical Sciences, when you actually cost them, are twice more than what the scheme is paying out to be. And we're well aware of those facts because you just heard that you yourself said investments have gone into private sector. There's no more land available free, by the way. It's all actually paid for heavily. We all know it. There is all the cost of maintenance of the high-end equipment. And we're talking about even secondary services. We're not even talking about tertiary and quaternary services. And then we have expertise and maintenance and cleanliness and all those issues. All of those cost money. You put those into cost. One wants viability of the schemes. These areas have developed, the private sector has developed well. Nobody should be profiteering out of it. Just like everybody is feeling that we want to do it for the nation now. We want to be part of this whole revolution. 10 years from now, every private system would be sitting happy saying, we're a part of this great scheme because all of us are doing the same thing, benefiting India and still being viable. I think you have a great opportunity ahead of you. And by the way, this thing about argument about just numbers of scale, changing everything is not going to happen. It'll happen only if we create a bottoms-up approach. New hospitals may come in 5 years later, which are built to fit into the scheme and say, now we can serve these patients. But that doesn't mean that we throw away the old system. We have to keep it viable so that new bottoms-up approach can come in and be a part of the scheme.
Well, final thoughts on the dialogues tonight. And Dr. Shetty, I'll begin with you because I know you're heading for surgery just now. But Dr. Shetty, you've described your hospitals as the Walmart model, that you've adopted the Walmart model. But when we look also at the other aspects of the challenges that faces the Indian healthcare is, of course, shortage of doctors, shortage of nurses. I mean, look at the India average as compared to the world, to the WHO recommended average. And of course, it differs in states like perhaps Delhi and Tamil Nadu. But the ratio of doctors, Maharashtra is introducing a scheme which they give you a quota if you go to rural areas. How do you have an equitable standard of service across India unless we address these issues? A health insurance scheme is very well received, but it's addressing the one end of the problem. What about the initial end?
Sonia, India requires 65 million surgeries a year, and only about 26 million surgeries are done. We need to do about 40 million surgeries, and we only have about 18,000 practicing surgeons. With that many numbers, there is no way you can do 40 million surgeries. So the biggest bugbear, we always criticize the public hospital. With 80% shortage of medical specialists, you really don't expect much from the public hospitals. Our biggest problem today is shortage of skilled manpower. Unless we address that, no matter how much we fund these schemes, it is not going to make a difference. But good thing is, government has launched the National Medical Commission, and we expect amazing things to happen. There are two things. One is Ayushman Bharat will pay for it. I know they may not pay how much we want, but I know they will pay sufficient. At some point of time, I'm confident. Right. But once the National Medical Commission produces enough number of doctors, believe me, we will become the first country in the world to dissociate healthcare from affluence. We will prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy.
Thank you, Dr. Shetty. Of course, I think the most fantastic thing about it is that we're talking about health, that whether it's a government in Delhi with Mohalla clinics, whether it's the Prime Minister with PMJ and Ayushman Bharat, whether it's Andhra Pradesh, Telangana, Tamil Nadu, health is becoming a political priority. Dr. Guleria, because of course, as I said, you see patients from everywhere. I mean, even patients who can afford it come to the AIIMS because of the quality of care, and people who literally, and this of course is studies have shown that the biggest reason for people falling back into poverty is out-of-pocket health expenses. So in that sense, what do you see as a larger problem? And of course, overworked doctors. That's an issue of shortage which we were just talking about as well.
So I think there are multiple things. One is, like you said, overworked doctors, and we need more human resources, whether it be doctors or nurses. And I think that's another area where the private sector can actually come in. A large number of private institutes don't teach and don't produce doctors.
That's a good point.
Using the DNB mechanism where you have the National Board of Examination, we could produce a large number of doctors just by the private hospitals coming into a teaching cadre. Currently, most of the teaching cadre is basically the government hospitals. One way of getting the manpower in is by having more and more private hospitals become teaching hospitals, and be involved in producing better quality doctors, better quality nurses. They have the skills, they have the surgeries, the number of patients. So that is one way to increase the manpower. The other thing is, like you said, which is really heartening, is that health has now become a political issue, and it is something which has become a major issue. Health was never an issue. It was basically roti, kapra or makan. So it was never something that people talked about. The fact that now health is being discussed means that there is a focus on it, there is a political will, and that is why the Ayushman Bharat, the wellness clinics, and all these things have come together. So I think things will change. We have to change our mindset, we have to get people to look at it. We could have packages which are across the board, irrespective of whether they are through Ayushman Bharat or whether the patient is paying for it, which are standard packages which the government agrees to in government hospital, which is also agreed in private hospital. So even if you are not in the scheme, you know that if I have to get a bypass surgery done, this is the cost which has been now approved as per the government. Ayushman Bharat will pay for it, but if it's not paid, I don't come into the scheme, I still know this is the amount I have to pay. If I have to go for a knee replacement, this is the charges.
There are no hidden costs.
So there are no hidden costs. So if you have a broad package which covers everything, irrespective of whether you are in the scheme or not in the scheme, that will have a lot of transparency.
So a range.
So we could actually look at that, and that would actually be very, very transparent. No one could say that I went to this hospital and I was overcharged. You know your package, and you know this has been sort of approved by an institute or a government body, that this is a package which is sustainable, which is acceptable to the patient, but it's also acceptable to the hospital, that, like we said, that fills its need but doesn't go to the greed area.
And a standard quality.
And it offers standard quality, and that quality assurance can be done.
I was just going to raise an important point, and I will say that Dr. Indu Bhushan has been smiling, and I think he knows this all, and I think that's the best part of him. I've always found him to be really a thinker. He's not on all these aspects. He's smiled because he's been thinking around it. He's been thinking of the solutions, and perhaps a year later we'd have solutions to many of the issues that we've raised. I just want to also encourage him to think on the quality lines. While we may say NABH certified hospitals, etc., I think the biggest indicator of quality is if the patient is being readmitted or not, a procedure being redone. I think those are the parameters he's going to think through, because biggest quality outcomes, which is measured perhaps across the world by every peer, is mortality and readmissions. And I'm sure that that's what you're going to build in, because you don't want procedures being done and suddenly see the same procedure being repeated 3 months down the road. That's not good. And therefore, I think that's a robust system that he's going to build in times to come. I think I would encourage that. And I think the second robust system I still believe is a transparency in the pricing policies. Be it whatever the pricing. It is not to be said this is a low price or a high price. But if it's an inclusive pricing policy, it actually includes, you just mentioned it was PGI, we mentioned there's a FICI one. Why it's got to be that? Why is the pricing policies got to be thought through differently? It's, after all, sitting at the same side of the table. This is the future of this country. Partnerships have to emerge between private and public sector, right down to the grassroots levels of the primary care centers.
Partnership is a good,
and therefore, the pricing policies should be so transparent that everybody is accepting
I think partnership is a good point, and of course, of training doctors. Dr. Sangeeta Reddy, final thoughts from you tonight.
I think we cannot say the word Ayushman Bharat without saying we're so glad that universal healthcare is the mission of the country, and it's a collective mission. I know there are many things that need to be done. We've spoken with Mr. Indu Bhushan, with Mr. V.K. Paul, about the power of using this tremendous coverage. One is to boost positive health in the country. Second is to digitize and use this data. Third is to focus on prevention so that the actual burden of disease comes down. I think also there are things to be done on this road and this journey. We need to find ways to encourage private sector to come in proactively, maybe to innovate and build new models. Right now, I think the scheme says that we have about 500 million people who are covered and about 45 lakh beneficiaries. This number is going to grow fivefold. We need to ask ourselves, are we ready for it? We must look at the adequacy of beds and the adequacy of manpower. We must use technology to upskill people. Nurses should become nurse practitioners. We should do role enhancement and use technology towards that. So as we bring down the burden of disease, as we enhance the coverage, as we ensure positive and proactive healthcare, the only way that we can really achieve all these tremendous things is if we think win-win for everybody in the system. We think win-win for the patient or the healthy individual, for the private sector, the public sector, and the administrator. So I truly believe that there's no looking back. This new and exciting phase of Indian healthcare has begun. We are committed to partnership, to training, to learning, to innovation. But we expect that we will be acknowledged for the role that we have played, given true partnership for the path that we can take going forward. And I think there is a significant intent to continue to do good for the country as we have done for the last 36 years. So here's to a great new era in Indian healthcare, to universal coverage, and congratulations.
Right, Dr. Indu Bhushan, it's only been a year, as you said, and when you came in at a time when, of course, we still know the many inequities in the system, where you may have a hospital in Uttar Pradesh where a woman may give birth on the floor outside, where you may have also the best hospitals which are comparable with those in the world. When you look now at what's left to be done, what would you say is the biggest lesson that needs to be learned, not just for Ayushman Bharat, but for the Indian healthcare system?
Well, one thing which I probably must emphasize is that while I agree that we need to have more doctors and more surgeons, but also the distribution of these doctors and these hospitals need also to be changed. Because right now, 80% of our tertiary care hospitals are in, I think, 8 or 10 big cities. And so with this Ayushman Bharat, where we are creating a lot of demand in tertiary or tier 2, tier 3 cities, rural areas, I am hoping that this imbalance will change, and that itself will bring about some efficiencies. And you started with asking the question that what we have learned, and I keep saying that we learn every day. And this panel actually has been a very learning opportunity for me, and I've got some very good suggestions. And in a year's time, you will see improved version of Ayushman Bharat and Ayushman Bharat 3.0. And we'll continue to make changes based on the learnings that we have.
This at the end of the day is all about people. Which are some of the cases that have touched you the most, or even one case that has touched you the most in this 1 year? Because you've traveled around the country, I know, for this.
Actually, large number of cases. And there was a case from Bihar. That person borrowed money and came to a hospital because he, actually it was a man, because he didn't, he actually came to Delhi, Safdarjung. And he came and by accident found out that he was Ayushman Bharat patient, and he was not charged anything, and he went back with the same money and he returned it to the money lender. And so when you talk to him, he had the tears in his eyes that because of Ayushman Bharat, he is now going back, he will not be indebted for his life, and can continue normal life without poverty.
Absolutely. Well, Dr. Indu Bhushan, all of you, thank you so much for sparing your valuable time for being on this panel. Congratulations. I must add my congratulations also to this. And
there will be a million of souls like this thanking Ayushman Bharat. Yes,
and I really think I said health, not just the political agenda, but also on the mainstream media agenda, and all of us. That's what we need to vote for. That's what we need to see change. And hopefully all of us are on one platform on that. Thank you.
Thank you.
Thank you very much. Thank you.